Hi, I would like to thank you all for being here. This is a very nice opportunity to see parents, children, researchers, and clinicians. We are clinicians, and my name is Marianne Kasius. I'm a child and adolescent psychiatry. I hold teaching positions at the University of Leiden and Rotterdam. And next to me is Clary, and she will take you to the practical part because we've heard a lot of research about FOXP1, which gives a lot of hope for people, which is always good. But I've also heard about parents that didn't feel understood when they first came with their children to us clinicians, and we can learn a lot from you. We we work at the Banyard, which is top GGZ, which is a top clinical mental health facility in the Hague. We treat children with mental disabilities and psychiatric symptoms. This is very important because all this research leads to a lot of knowledge, but the knowledge has to be transported into treatments. And to be a top facility, you need to make adjustments in your diagnostics for children with disabilities. You may have to do teaching for new professionals. You have to do research, and you have to practice what you preach. We all do that. We all know that there's a complete lack of tailor-made interventions in the field of mental health. And we just started, I think, 10 years ago to adjust everything and to research that. And sometimes that's on an NS1 basis, but it's also learning us that a lot of children with mental health issues need special treatment that is geared towards, their problems. We just met a mom, and maybe I can tell about. She said, I went to this other facility, and the child needed training, and she said, well, this will not work or that will not work, and they said, well, we just have this protocol and we'll do it this way. That doesn't work. We know that. So we always try to gear with you what works for your child and what doesn't work. So the research provides insight in ways in which innovative interventions might work, but we need you to tell us what works and what doesn't. In our facility, we see a lot of children with mental health problems, and in a lot of cases, they have severe mental disabilities, and there's a greater chance of detectable genetic abnormalities. Saskia yesterday told that one day she met one child with FOXP1. I was trained at Mount Sinai at the Seaver Center. So I met in this whole period of seeing all these autistic children, I met one child with a FOXP1 that was diagnosed. And second one was Fan, who came to me in the Netherlands, and he said, Marianne, you've seen one child with FOXP1 as a child psychiatrist. Can you try to, to help us in treating the symptoms? I said, of course, you know more than I do, but I will try to find everything I can about, the syndrome and the symptoms and what we need for treatment. We do this for other groups too. We see a lot of children with Down syndrome, Fragile X, Smith-Magenis. And for example, we have in Rotterdam, we have a group with the Prader-Willi syndrome, which, also have specific problems, but you can hear we do the same thing as you do here. Now we have a treatment week where we have all the children together. So we are very interested in seeing your children in the base camp to see what's happening there. And we try to do that for a lot of other syndromes as well. As you know, as a child psychiatry, I was trained at Mount Sinai, and I was very well learning about the FOXP1 syndrome. You probably all know, but like 24% are diagnosed with autism, 75% are diagnosed with ADHD symptoms, 38 are diagnosed with anxiety symptoms. 95% of them have repetitive behaviors that are not always linked to the autism. So here comes the here comes the psychiatrist, says that you need psychopharmacotherapy, but that, as you probably all know, doesn't always work. So we have to find ways that might it work a little bit with a little play therapy? Might it work a little bit with parent therapy or treating the other children in the family? I've done it all, been there. It's very difficult, and you have to be very specific. In the case of FEN, we have to this big discussions with the pharmacologists to make us little pills that had very small doses of the medication, and you have to go to the people who will make it, if they want to make it, who will pay for it, and they want to know results. So it's good to do it, but you always have to work together. So there came on our focus on, we have this team of doctors, psychiatrists in training, we have medical students, and they all need to be taught about what you need for diagnostics, what you need to adapt for treatment, and what you need to adapt for psychopharmacology in concurrence with other therapies. And there we come in with, we have EMDR, we have play therapy, we have nonviolent resistance, we have loss of bereavement therapy for parents, we have treatment for their brothers and sisters. But we all have to gear those treatments specifically for the symptoms that occur at that time. And I don't have to tell you, a little child with FOXP1 will have very different problems from a child that is in puberty or even beyond that. To give you an example of what we can do, Clary will start with presenting the play therapy that we adapted for 2 of our FOXP1 patients.
Thank you. You want to click for me? Okay, thank you. Okay, as a play therapist, I would like to tell you more about the treatment of a boy with a 7-year-old boy with a FOXP1 syndrome and an intellectual developmental disorder. And because I have to speak in English, I need my cards, so sorry. Okay. The boy had a huge sphere of hair. Whenever he saw a dog or baby hair, he would gag, almost spit. Treatment was indicated because of anxiety complaints and concentration problems. Even cutting his own hair was very exciting for him. Treatment was applied through storytelling supported by play therapy. Storytelling is a form of EMDR. A story is told with the aim of conveying a message and to regulate emotions. In storytelling, the story has a structure. The story begins with a description of what the child is good at and how much the child is loved. Then something really bad happens in the story. The fear and the pain are described in detail from the child's feelings. And in the end, there's comfort. The event is over, the child is safe, and he feels strong. 2 stories were created related to his fear of dogs and an unpleasant experience with a hairdryer. The use of concrete materials, such as a living dog, or the hairdryer of his mother, and a real brush with hair, forms an essential part of the therapy. These materials help the boy to confront and process his fear in a safe environment. Before each session, a fixed ritual was introduced. For example, the boy and I were making together a very funny rhyme. And there are a lot of Dutch people here, so I can say it. It was about tip-top-toppy, you have a very smart copy. And he liked that, and every time did it before the session and after the session. The boy was also involved into the process, for example, learning the butterfly hug. It's a kind of self-embrace to comfort yourself. And if you like it all, you can do it. So cross your arms, put your hands on your shoulder, and tap on your shoulder by saying, "It's okay, it's okay, I can hear you, it's okay." Yeah. And maybe you can feel it already, that it calms you down. And if it isn't, you have to try a little bit more. After each session, the boy was allowed to play. Play therapy is a treatment that helps children to express their emotions. Let me now read you 2 parts of the story his mother made for him. I need my brush. What did Mommy do? Yuck! She pulled all the hairs. She pulled all the long fluffy hairs of the hairdryer. One after the other came off. Mommy didn't realize that a little boy saw this, and certainly didn't realize that he might find it scary and gross. What was the little boy thinking now? What was the little boy feeling now? Was he scared? Did he feel alone? The little boy felt sick, but Mommy didn't notice anything. The little boy thought it was really gross. Mommy kept pulling hairs off the brush, and to need 3 hands, she folding them into a ball. Ugh, ugly. So the story goes on. Yeah. And maybe you can tap, and luckily there was a good ending. The little boy was happy and relieved that Mommy and Daddy had explained that there was nothing to be afraid of. And the little boy now became a big and smart boy. He knows that there's nothing to be afraid of. Hair is not scary or dirty, but nice and warm and soft. All nonsense. He, ha, Harry, nonsense. Harry is a character of his favorite book. By repeating the stories and practicing with real material, the boy learned to control his fear. And in the end, he was able to touch the hair without gagging and showed less avoidance behavior. He was better able to correct himself in fearful situations with the butterfly hug. The family could also undertake activities outside the home more easily. The other case is about a boy with regulation problems. He constantly seeks verbal confirmation and physical proximity from his parents. He has difficulties dealing with frustrations and unexpected changes. The play therapy focused on increasing his self-regulation skills. A self-regulation plan was drawn up that matched his interest, particularly his fascination with sharks. An emotion thermometer with colors, green, yellow, and red, was introduced. And when there were signs of increasing frustrations, the boy was given a yellow shark. And when he feels angry, he was given a red shark. At the same time, he was encouraged to do activities with the sharks, such as jumping on a trampoline or swinging. And that helped the shark, but of course also the boy, to calm down. Once the emotion had stabilized, the boy was offered a green shark. And the red shark and the yellow shark could swim away. Next one. This promoted his self-awareness and gave him tools to calm down. The boy learned to recognize and regulate his emotions better. The frequency and the intensity of his anger decreased, and he was able to function with less guidance from his environment.
Thank you, Clary. As you might notice, I didn't come in here because those kids were referred for pharmacotherapy. And I said, you know, I can start pharmacotherapy. They need something special. And we did that. And a lot of work goes for Clary, who gears these programs, if necessary, makes the sharks, puts the thermometers on, and the stories. But so the concrete and personal material is very relevant. So we need to invest in, getting to know the child, getting to know the problems in the environment. So we also have, which is very unpronounceable for anyone who's not Dutch, GIJS, which means GGZ in je straat, which is a mental health facility room that is in a bus, and we can take it to facilities or homes or people at home if the child doesn't want to come out, and it's very small, and if you're confined, so we get to know, to learn the child, to see what's the problem, and if we can gear this treatment towards the child. Storytelling in therapy works very well, and it also involves the parents who we need to make the story and to tell the story with the child. So integrating this play therapy intervention helped us very much, and we're investigating if we can do that for other syndromes also. We have from this previous conference, some people came to us, can you help us too? And because we are top GGZ, we can offer treatment through all of the Netherlands, luckily, because of the finance. But we can also try to make it online if possible. So if there's any questions, I will be here at the tables to try to help you and try to get your information and your stories of what worked and what didn't work, so we can integrate that also. We would like you very much to thank you very much, and thank Annemiek and Esther for inviting us here to make the bridge between research and clinicians, because I think that's, with the help of you parents and children, the most important we can do. Thank you.